want you to, when you're doing this metabolic case study, we had a discussion in the Unit 10 discussion area out in the main forum, and we had a discussion about PCOS versus metabolic syndrome versus prediabetes versus elevated insulin levels in the blood. So, but I want you to remember what you're talking. You know, you have to figure out. A lot of the times, it all seems very intertwined, but try to tease it out a little bit. And when you're looking at Sandra right here, the question is, on her first question, what are her risk factors for type 2 diabetes? So she's coming in, which a lot of people do. They're coming in for problems with their menstrual cycle. And, you know, a lot of times they won't have had a period in 3 or 4 months, 6 months, and they don't know if they're pregnant. They're at risk for pregnancy because they've had unprotected sex. So a lot of times they'll wonder if they're pregnant or want to be pregnant or concerned because they haven't had a period, and that'll bring them in. But then you find all this other stuff. So you've got this person that, you know, that has, you know, she's obese, and she's got some other things going on. She has type 2 diabetes in her family, those type of things. She's ethnicity puts her at risk. And so what are her risk factors for metabolic syndrome? So remember, metabolic syndrome is not PCOS. PCOS is something else. But a lot of times they have both things. Okay, so what are the risk factors for metabolic syndrome? So start to see those things as different things. They're not the same problem. Okay. So what are the physical signs of metabolic syndrome? And what I was getting in this question was I was getting no period, facial hair, and that's PCOS, not metabolic syndrome. So think about metabolic syndrome, which is actually, you know, there's some controversy about that term and what it means and the diagnosis, and you can go into up to date and kind of see the diagnostic criteria for that. You know, abdominal obesity and those type of things, the cholesterol. It's a syndrome, and when you say syndrome, it's kind of a conglomerate of symptoms. You know, it's kind of these things that are kind of all playing together in one place. So what laboratory test would you order to assess insulin resistance? So we're not ordering tests to see if she has PCOS or metabolic syndrome. We're looking at what is going to assess insulin resistance. Okay, so a lot of times when people are insulin resistant, they also have prediabetes. You know, so is it prediabetes? Is her A1C 5.7 to 6.4? Is her fasting glucose 101 to 126? Is her oral glucose tolerance test from 150 to 199 2 hours afterwards? So is she in that prediabetes phase? And what if all of her sugars are normal, and then in her fasting serum level, serum insulin level is high? So, you know, that's what we're going to know. Insulin resistance. When people have insulin resistance, the insulin is taking the sugar out of the bloodstream and into the cells, right? It's like the bridge. The insulin is the bridge. And so when the bridge is, you know, it's not quite connecting, there's resistance to that, then your pancreas spits out a lot more insulin to shove the sugar into the cells. So the insulin levels rise because it takes more to shove it out, you know, to get it out of the blood and into the cells. But a lot of times the blood level of the sugar in the blood, the glucose, it remains normal for a long time. So you have these things going on in the background, and so you need to kind of think about those things. Then we have here, does she have diabetes? Does she have metabolic syndrome? Pharmacologic and non-pharmacologic. Now we don't treat metabolic syndrome with metformin, right? That doesn't treat, metabolic syndrome is not treated with metformin. We treat insulin resistance and prediabetes with metformin, but they all play together. You see what I mean? A lot of times we have one thing and what you have another. So that's why it kind of gets all intertwined. It's sometimes a little confusing. So just zero in on whether which one you're working with. You know, what is the question about? Are you treating your patient for PCOS? Are you treating them just for their prediabetes? Are you working with their metabolic syndrome, with their elevated cholesterol? You're looking at this patient holistically, but when you're talking about testing, be sure and read the question very carefully and know what it is the question's about. And don't assume that somebody that's overweight and has acanthosis nigricans also has PCOS. Don't get them all intertwined. Just be sure and be careful on the question that you're actually answering. Okay. Somebody sent me a note and they wanted to know about diabetes medications, and we've really talked quite a bit about the metformin and the risks of that. But in the ADA guide, if you get this management of hyperglycemia and type 2 diabetes, the guidelines are not current. But what is in here is, and you'll find these other places too, but they've got all the drugs. They've got a nice chart with the medications, and so this is what I like in here. I don't know if I can't make it bigger on my screen, but you'll want to kind of know some of the kind of the prototype drugs and what you're going to look for, with the metformin, know the class, and know the mechanism of action, and no weight gain. It's very little risk for hypoglycemia. You're going to be at risk for lactic acidosis. People with chronic kidney disease, if they're, I think the actual guideline or the actual drug information says a GFR less than 60 or less than, what does it say now? I'm not sure exactly what it says. You can look at Hippocrates, but what we're going to look at is the GFR with chronic kidney disease. And so you're going to want to, in practice, you may see people on metformin down to estimated GFR of 40, and that's not uncommon. But I think that there's a number in Hippocrates or in the other, in the information that you're going to find on drugs. You need to go with that, even though in practice you may see a little people stay on metformin longer. Okay, sulfonylureas, those, you've got to be careful with those because of sulfa allergy. It's sulfa, sulfonylurea, glipizide, glymepromide. There's only one of these drugs in the sulfonylureas that is not processed by the kidney, and that's the glipizide. And so when people with chronic kidney disease, you can still use glipizide. And these drugs are cheap. I don't like to use them that much because what they do is they just kind of keep stimulating the pancreas to shoot out insulin regardless of what you eat. So, if you have somebody that doesn't eat, and they're at risk for hypoglycemia. And the Beers list for old people, the drugs that are not very safe for old people, glipicides are on there. Because of that reason, because they don't eat all the time, like they don't always eat consistently. Okay, so when you can give metformin, use it all day long with insulin. And sulfonylureas, it increases insulin secretion. When we start on insulin, we don't give them sulfonylureas. They're not indicated to use together. And I'll see that a lot. I'll see patients come out of the hospital on a sliding scale. Now they're in the clinic, and they're on a sulfonylurea and a sliding scale from the hospital. So you got to be careful with that. So hypoglycemia causes weight gain, things like that. Okay, so I don't use these neglicides very much. The TZDs, they're just about extinct. They're an insulin sensitizer also, but we have all that stuff with the increased heart failure, with the rosiglitazone and all the lawsuits and things like that. And I just don't. They're a good drug, but we just don't see it that much anymore because of the fear of lawsuits and things like that, right? So edema, heart failure, bone fractures, they have some effect on your cholesterol, things like that. So acarbose, neglatol, those are to give for postprandial glucose spikes. That's what we're going to use those for. So I don't use those much. Of course, I work with a lot of older people and with advanced disease. And you have to know that diabetes is a progressive disease. It's progressive chronic disease. And no matter how hard your patients try, eventually the disease is going to progress. And that's what we had a discussion today a little bit about, the prevention of diabetes. And so there's, they say that metformin and pre-diabetes can prevent diabetes, but it's really more of it sort of delays onset. But if you have somebody that is, overweight and they do lifestyle modifications and they take the metformin, they could prevent them ever from developing diabetes if they truly change their lifestyle and, take their medications. But, you have somebody at 5.7 to 6.4% on their A1C, and you give them metformin, they go down to 5.6, and they never get up to 6.4. Do they have diabetes or not? I don't know. They had pre-diabetes. They never got a diagnosis of diabetes, but if they stopped taking metformin, they would have diabetes, right? All of a sudden, they'd be at 6.8 because it's progressive. So we don't want patients to think that they are a failure when they have to take insulin, when they need insulin, because insulin is actually wonderful. I mean, it's wonderful. They can take one shot a day, they're done. They don't have to take 3 different drugs. And we don't have to get patients on 3 different drugs before they start on insulin. When you look at these different medications, most of these medications will reduce the A1C by 1%. So if you have someone come in the door at 12%, you give them 3 drugs, they're going to be down to 9? And you would want them to be at less than 7 if they're a normal age, or less than 6 if you're going by other guidelines, like the endocrinology guidelines. So, but less than 7 is fine. Less than 8 for old people, and it just depends on how they are. You might have an old person that is, really with it, and they have a hypoglycemia awareness. They're not on the beta blockers that hide the hypoglycemia, and they can really manage their diabetes, and you want them a little more tightly controlled. Also, if you have somebody who is, got an infection, they got an infection in their foot, they got a bladder infection, whatever it is, you'll want to make sure that they're a little more tightly controlled, and that's when sliding scale is appropriate. Bile acid sequestrant, no, I don't use those too much. So you've got the GLP receptors, those are the injectables, exenatide, those type of things, and you're going to have, they promote weight loss, and they're working on different areas. If you ever seen that little chart that they have, and it shows pictures of organs, and it'll show a pancreas, it'll show the gut, it shows the liver, and it shows where all these drugs are going in. And I tried to find it before I started, but anytime you go to any kind of educational sponsored dinner or whatever, they always bring this chart. And I'm going to try to find it and put it up there. But what you want to do is you want your drugs for diabetes to work on the different areas. You want them to work on the gut, you want them to work on the kidney, you want them to work on the pancreas, or the gluconeogenesis. You don't want to attack it from one standpoint. If you're going to do drugs, do different, have them go from different areas, work on different organs, so that your control is more multifactorial. You got them, they're all working together. Okay, so you have the insulin. And then those are pretty easy. We're not so much, the basal bolus is really where it's at today. We're using the Lantus 11 here. Lantus doesn't have a peak. It's, you and I, our pancreas is just spitting out insulin all day long at a basal level. We're producing insulin. And then when we eat, our body shoots out insulin to cover that meal. Well, when we do basal bolus insulin, we do the Lantus 11 there, should be the base insulin, and then when they eat, we give them some more insulin, which is bolus, and that mimics the body's natural response to diabetes. Okay, and that's how you and I, as healthy people, that's how our pancreas handles food. There's a lot of other things going on with gluconeogenesis, the gut. All of that stuff is going on, but in a simple way, that's what the pancreas is doing. So Lantus has no peak, and it usually lasts 24 hours. It really has just a level. And Levemir does have a peak. It does have a peak, and it usually lasts about 18 hours. So a lot of times people will dose Levemir twice a day. And I prefer to give Levemir in the morning and give it once a day, and that way the next morning the sugar's a little higher. And I would rather have them sugar be higher in the morning when they wake up than have it being lower in the morning while they're sleeping or at night. I would rather, if they're going to have a peak, I'd rather have it during the day when they're eating. Okay, so I usually use Levemir, Lantus, that's my favorite one because there's no peak. And it's the lowest, there's a lower risk, when there's no peak, there's a lower risk for hypoglycemia in everybody. Okay, and I still have patients on, 75, 25, and it's usually Novolog and an NPH. It used to be regular NPH, and, regular insulin peaks after, it wears off after 4 hours. So if let's say that you're giving somebody an insulin at breakfast, and unfortunately they're on a sliding scale. They're not in the hospital, they're home on a sliding scale, so they came off from the hospital on regular, so they got their regular at breakfast, and now it's noon, and the regular hasn't worn off yet. So then now their sugar at noon is 180, and it says give 3 units. So now they give 3 more units of regular. And so that starts 4 hours. And then they go on to, 16, and so what you have is a stacking up effect. So what we do is we do Similac, Novolog, which are rapid acting, not short acting, but rapid acting, so that within 3 hours you have a peak and it peaks and then it goes down. So when you check your sugar again at 11 o'clock or 12, that all the medicine's worn off, so that when they give them more medicine, you have a shorter peak. And you always see these little charts of the peaks, and that does mean something. It does have meaning. Okay, so I do some people on 75, 25, things like that, but usually I'm doing the basal bolus, and sliding scale should be used when periods of acute illness, times when you don't know what the dose is, how much insulin they need. It's like, oh my God, this person is at 300 now, and I don't know what they are, so I'm going to do sliding scale, and then I'm going to have them keep track of it, and then I'm going to find out how much insulin they're using, and then hopefully get them on 2 or 3 units with each meal, or, something like that. But what you usually see on a sliding scale is they wake up in the morning and they're at 100, they get no insulin, and then by noon they're 250, and then they get, 6 units, and then at dinner they can be even higher, or they can be bottoming out. So if they're getting 8 units a day, you want to split that up between meals. So there's lots of different strategies. But just keep in mind that with the insulins, you want to know how long they last, and focus in on those basal bolus insulins and understand those. And then you have the DPP4s. Are those even on here? Did we see those? Oh, here they are. Okay. So DPP4s are the Januvia and Tradjenta. Okay, these are the generic names. I use mostly Januvia and just Tradjenta, and they're working on the increased insulin secretion, and they decrease glucagon secretion. So they're working on a different area, and they work really nicely. And Tradjenta, Tradjenta, can be given in renal failure. There's no renal dosing, and then Januvia is processed by the kidney. So if you've got your sulfonylurea, and you've got one that you can give in kidney disease and one that's not, and same with DPP4. And then there's some new drugs, and they're like they're not on here. They're the GLLT2s, and those are the ones. I think those are the ones that they don't let the kidney reabsorb sugar. And so I don't think you're going to see any testing on those, but they work really well. But the risk is dehydration, because the sugar goes out in the urine. So you get, it works really well for controlling blood sugar, but you have risk for yeast infection because you've got all that sugar down there, right? And then also dehydration, because where the glucose goes, so pulls the sugar, it pulls the water. So, it kind of sucks the water out with it. So those are kind of the risks there. But just kind of, on our particular test, we're not going to have a lot of drugs, but just zero in on the classes and the major risks, and the things you're really going to worry about with your patients for those drugs. you know, and we're not going to be doing dosage, but I don't know. You can look at for the boards. You can look at some of the review books and see if they're testing on those type of things, on dosages and things like that. They might get a little more specific. Okay, so where were we? Any questions on that? I know I kind of went through them real quick, but it's not because I want you to memorize it all. It's just because I want it to be on your radar. You know, the medication, the safe medication administration and prescribing. Okay, so what else do we have? We have the diabetes quiz, right? I did open another pulmonary one quiz too. If y'all want to go back in there and look and see what some of those questions are. Okay, so let's see the diabetes quiz. I know that y'all know a lot about this stuff. I can see all the reading that you've been doing and all that type of thing. So you want to take it together? Okay, screening for adults for type 2 diabetes should be considered when patients are overweight and have the following additional risk factors. Check all those boxes. Well, overweight, right?
Yeah.
What do y'all think?
Firstly, yeah, ethnicity, yes.
I got to walk 30 minutes 5 days a week. That's bad, right? Don't do that. Okay, cholesterol, that's good, right? HDL 70. Well, less than 70, you want it, you know, the higher the better. HDL, you want high, right? And these things are all so intertwined. You know, all these chronic problems just love to be in the same person, right? Screening for children and adolescents for type 2 diabetes, and we're talking about children and adolescents. So they have to be overweight and in the presence of how many additional risk factors?
2.
So So you're gonna want to know what those risk factors are, and that's going to be important because you know you don't want to you want to assess do your screening according to the evidence, right? Okay, true false. Diabetes cannot be prevented. Regardless of how well people take care of themselves, conversion from pre-diabetes to diabetes is inevitable. I think we just talked about that, right? We have to have hope, right? And people, you know, lifestyle makes a huge difference, and that's not always, you know, it's not easy. And weight loss is difficult. Lifestyle changes are difficult, and it's also, you know, it's relapse. People who lose weight kind of gain it back and things. Diabetes is best managed by members of the healthcare team that have a special interest in diabetes. Yeah. Members of healthcare team may include, and that's, you know, all of them. So, and it really is. I mean, when you start to include everybody in the conversation on how to help somebody, it really is fun. It's a fun conversation, and it makes everybody feel like they're a part of the, you know, as part of the solution, and they come up with great ideas. Diabetes should be formulated in collaboration. So with the patient and family and healthcare team, they have to be involved in the plan. It's their plan. The plan should be individualized. And take patient preferences into account. Now we may have touched a little bit on the Affordable Care. I'm not Affordable Care Act, but accountable care organizations and how they, you know, their reward practices for meeting goals like A1C goals, and they also punish practices for not meeting goals. And so when you have a patient that says, you know what, I'm pretty good with the 10 A1C. I don't want to take all those drugs. That intensive therapy, it messes up my quality of life. And, you know, by ethics and patients' right to autonomy, they're allowed to do that. And so what's going to happen, what the fear is that these patients will be fired from practices because their A1C is not controlled because they're messing up the money, right? So it's really diametrically opposed to what, you know, we're told by the Patient Bill of Rights and then what the funding is. So, okay, so it should be individualized and collaboration, but what we have to do is try to motivate them to want to do better, right? And want to have better control, but they don't have to. They can do whatever they want. Okay, the management plan should include diabetes, self-management education. And if you see a DMSE, what I want you to know is these terms, because these are terms that you see, and they mean something. So you've got the education and support. So you have DMS, diabetes self-management education and support. Okay, so you want to know those terms a little bit. Now, it's not super important. I'm not going to test you on those, but for in your practice and when you read guidelines, know what that means. Okay. And hemoglobin A1C testing for people with type 2 should be ordered. Okay, so they've already got type 2 diabetes. How often do we check it?
It depends.
There you go. Perfect. Okay, so if we make a change in their drugs, we want to do it in 3 months. That's pretty much what because it's an average of 3 months, right? So if I increase their medications or make some change, I do it in 3 months. And then I think the guidelines say everybody should have it at least twice a year who has type 2 diabetes. I think. But it depends on what they're doing, what you're doing with them. Those questions are easy, right? A patient with an A1C level of 9% has the average glucose level of 212. So I think the answer's falling. I think it's fine or no. I have to look at the chart, but you have the chart in up to date, and all it is it gives you, if it's 8%, this is what the average glucose is. So, but what I have is I have people that come in, and their A1Cs are 6.5%, and then I look at the glucose record, and I see 200s and 300s. So what that tells me is that if they have a high here, they've got to have a low somewhere. It's got to be somewhere because their average is awesome. So if you're seeing 200, somebody with 6.5 A1C on their finger stick, you better look for hypoglycemia because it's somewhere. It's in the middle of the night, right?
Yep.
At that 2 a.m. Okay, goals for glycemic control with people with diabetes it's 7% by ADA and 6.5% by AACE, right? But we're testing ADA, and those are lesser standards. Diabetes self-management education support, and there's your little things there, along with physical activity, weight control, control or loss, medical nutrition therapy. So when you see MNT, medical nutrition therapy, that's your dietitian. That's what they call it now. We're not getting a dietitian consult. We're getting a medical nutrition therapy, and that's really where they teach them. But also prescribe diets and things like that. So that's kind of the terminology. Blood pressure should be measured for people with diabetes every routine visit. What are their goals?
Less than 140.
Yep, that's right. And that's on the JNC8. It's in the ADA guidelines, but also if you look on the cardiometabolic risk on the ADA guidelines, but it's also in your algorithm for your hypertension. So they're all playing together. You've got cholesterol, you've got hypertension, you've got hypothyroid, you've got diabetes. They're all together. Okay, for patients with dyslipidemia and diabetes, goal of therapy is to tolerate a statin. So remember how, and some of you took this test and it was miskeyed. I mean, it still had a goal of less than 100 for LDL, but I changed the question. So you didn't get it wrong. It was my fault. For patients with dyslipidemia, we want to go by those guidelines and the AHA, ACCA, the new ones that came out in 2013 for cholesterol, and we all want a goal, and they don't give us one. They tell us the goal is they do a low, a moderate, or high dose statin. So we want to tolerate those statins. So you treat them like you do anybody else. There's no different goal. Okay, so when somebody is type 1 screened for nephropathy by urine microarray after 5 years, so those are microvascular changes. Okay, screened for nephropathy by urine at the time of diagnosis. So
The baseline.
is that right? We'll see. Usually through serum creatinine. We'll see when we grade it. And tell me if it's not right, because sometimes, you know, the old lady, sometimes you have to keep up. You guys keep me on my toes here. Okay, so when do we do their eye exam, their dilated eye exam? We do it every 2 years. Yes. Oh my goodness, should be evaluated for diabetic neuropathy. So, orthostatic hypotension? Yes, because it's found in vessels, right? They're controlled by, I think it's all of them. Constipation, yes. Brittle diabetes, yeah, because that means they're out of control.
Yes.
Rectal dysfunction, yeah, I think it's all of them. Any argument about that? Any other thoughts? I don't know, I'm not sure, but I think that's it. Okay, pregnant women, 24 weeks. That was that controversy, right? Everybody was like, oh, that's not enough, do it earlier. But this is like screening. If they haven't had a reason to be screened by 24 weeks, then screen them at 24 weeks. Okay, but if there's any reason to screen them before that, then you can do that. So I don't think that my test will be graded. I think there's some manual grading. Is there? Oh, okay. Breast cancer. So each one of these is a link. So it will actually take you to the resource when you finish the test. Individualized. That's spelled line. We'll spell it wrong. It was correct though. Okay. So that was true.
Yeah, about that.
Okay, you're right. You probably looked at the tables. Okay, so this is A1C. Yeah, I didn't answer that one, but there's different goals for different people. So just remember 7 for most. Okay, so you can click on it, and this is the cardiovascular disease risk management. It'll show you, the guidelines for that, and then you can click on it to get there. Right. So all of those are there. So that is an hour, and I know that we talked about a lot. Type 1 diabetes, you're going to see adults with type 1, and almost, I'm going to say every type 1 person is with specialty care because as a child they started with specialty care. And these are the people that you do glucose, you do carb counting, and you'll do the insulin pump. They're not producing any insulin at all. They're not producing any insulin at all. And you can do the C-peptide, and sometimes if somebody's a teenager, they're overweight, they have symptoms of diabetes. They have some diabetic keto. Diabetic ketoacidosis is definitely associated with type 1, but the hyperosmolar state is type 2. But there are people that are kind of in the middle, and we actually had a nursing student that was diagnosed as a child with type 1, and they did a C-peptide on her at 20, and she was producing insulin. So they don't really know, there was some confusion on what type of diabetes she had, but it was possible that they think that type 1 is caused by autoimmune or an attack, like on the pancreas, and so maybe it got better, a little bit better. So, but with type 1, you're going to want to know those, 1 through 7, identify that one, diagnose quickly and refer and get them where they need to be. And then you'll see people with type 1, but they almost always have a specialist. And then a lot of times they're going to have those insulin pumps and things like that. But don't ignore, when you look at that, at the topical index for, you want to look at the difference between diabetic ketoacidosis and hyperosmolar state, and be sure and know those complications, of diabetes. And then